Hi everyone, it's Judy Bramson and Alan Mozek, and today we're going to be talking about intellectual disability.
An intellectual disability, or general learning disability, is a neurodevelopmental disorder which affects intellectual processing, education, and the acquisition of skills for daily living and independence. A significantly impaired intellectual functioning is defined as an IQ which is under 70. What's also required are deficiencies shown in two or more adaptive functions. These are needed to identify that individual as living with the intellectual disability. Approximately 6.5 million people in the US have this diagnosis. 1 to 3% of the global population, about 200 million people. And intellectual disability is more common in low-income countries. About 17 people out of 1,000, or 80% of all individuals with intellectual disabilities live in these low-income countries. There are many causes, but for a large majority of children, the exact cause of this intellectual disability is unknown. Some congenital causes include Down syndrome, fetal alcohol syndrome, Fragile X syndrome, birth defects, and infections. Some of these can occur before birth and some after. As for older children and adults, most are acquired due to a traumatic brain injury or any sort of severe head trauma, infections, and strokes. So the most common causes are genetic conditions, complications during pregnancy, during birth, diseases, and exposure to different toxic elements.
Intellectual functioning plays a role in intellectual disabilities because we often see a deficit in reasoning, planning, abstract thinking, judgment, problem solving, academic learning, learning from instruction and experience, as well as a practical understanding determined through clinical assessment and testing with individuals who have an intellectual disability. Adaptive functioning is also at a deficit. This often includes conceptual skills, social skills, practical skills, as well as adaptive functioning that impairs an individual's ability to perform activities of daily life. There are different levels to intellectual disability. Mild intellectual disability, the individual has an IQ of 50 to 69. It may not be apparent in an individual until they start school and may be misdiagnosed as having a specific learning disability. They can learn reading and math skills equivalent to a typical child aged 9 to 12. They can learn self-care as well as practical skills needed for everyday life, and many do and can live independently. Moderate intellectual disability, the individual's IQ range is from 35 to 49, and it is usually identified within the first years of life. They require significant support at school, home, and the community, but can learn simple self-care and practical skills. Many live with parents in group homes or semi-independently with significant support. Severe intellectual disability is broken down into two categories: severe, which is an IQ of 20 to 34, or profound, which is an IQ of 19 or below. Individuals in this level usually require significant supervision and support for the entirety of their life. Many learn to participate in social or community activities to a limited degree, but they do require significant care and support to maintain a healthy and safe lifestyle.
Next, we're going to go into the impacts of intellectual disability on the individual. This can include their social interactions, friendships, romantic partnerships, and how they interact with their family. Living situations may vary depending on the severity of the intellectual disability. So individuals can live at home with their family or at a group home where they're assisted by support staff. Some individuals may live at home but participate in a day service or dayhabilitation or dayhab. Some individuals encounter health problems co-occurring with or caused by their disability. They may encounter challenges when it comes to diet and nutrition. They might not get all the sufficient foods to maintain their health. And consistent exercise might also be a problem. There are also impacts of intellectual disability on community participation and inclusion. So this participation may be limited. Support staff or a family member may need to accompany an individual when they go out in the community to ensure health and safety. The transportation support might limit access to community activities. If a individual wants to go to a certain activity, that may be limited if a family member can't drive them or if a support staff isn't available at that time. An individual with intellectual disability may have a job or do some work. An individual might not participate in a job per se, but instead engage in tasks or responsibilities out with family, maybe doing bottle return or at a group home or day hat. Perhaps they help design different cards, get well cards for hospitals and different charity services. Individuals with mild intellectual disabilities may be employed by a local business, but they might need a job coach to succeed in that career and help them manage their finances. Unfortunately, there are negative stereotypes and biases of those in the community, and this can be a source of frustration for broader interactions. A community may lack the understanding and training that a professional or instructor may have regarding these disabilities, and it could lead the individual with intellectual disability to feel alienated and misinterpreted. Some of the learning characteristics might be a difficulty learning new material, difficulty with communication and social skills, and a slow cognitive processing time. So due to these challenges, individuals benefit from increased processing time, repetition of that material to ingrain this new material, as well as visual aids and multiple approaches to instruction. Cognitive characteristics include deficits in reasoning, planning, problem solving, abstract thinking, and understanding complex ideas. And there may be a difficulty with efficient and experiential learning. Affective characteristics could include an increase in aggression, dependency, or learned helplessness, impulsivity, which might lead to a lack of safety awareness, gullibility. We talked about perhaps having a job coach to make certain that a person isn't taken advantage of financially. Passivity, low self-esteem, low frustration tolerance, which might dovetail into that aggression piece. And unfortunately, there might be a higher risk of self-injury and suicide. There are also different psychomotor characteristics, a delay in that motor development, adaptive functioning impairment, difficulty initiating, adapting, and maintaining their balance, limited voluntary control, and that low muscle tone. So this might be supported by, while school age services, including an occupational therapist or a physical therapist.
There are assessment practices that go into categorizing somebody as having an intellectual disability. Often a medical examination involving formal evaluation along with a complete physical screening, as well as an overview of family medical and social history. Psychological testing that assesses intellectual and adaptive functioning and involves behavioral as well as social observation. Severity of disability is determined according to the level of support necessary for daily functioning. There are two different systems used to classify intellectual disability in the United States. The American Association of Intellectual and Developmental Disabilities, also known as AAIDD, as well as the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. The American Association of Intellectual and Developmental Disability defines intellectual disability as a condition characterized by significant limitations in both intellectual functioning and adaptive behavior, and this usually originates before the age of 22. Instead of classifying by the severity of functional limitations, the AAIDD assesses severity based on the intensity of supports that are needed. These needs are typically identified using a standardized support need instrument, such as the supports intensity scale. The AAIDD system evaluates a person's strengths and abilities, not just their limitations or deficits. The DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, defines intellectual disabilities as neurodevelopmental disorders that begin in childhood, and they are characterized by intellectual difficulties as well as difficulties in conceptual, social, as well as the practical areas of living. The diagnosis of intellectual disability requires the satisfaction of 3 criteria. The first one being deficits in intellectual functioning, like we said, includes reasoning, problem solving, planning, judgment, academic learning, and is often confirmed by clinical evaluation and individualized standard IQ testing. There also has to be deficits in adaptive functioning that significantly hamper conforming to developmental and sociocultural standards for the individual's independence and ability to meet their social responsibility. And third, the onset of these deficits must be seen during childhood.
There are strategies to support communication. This may include setting clear expectations, consistency, clarity in speech, and direct language. So this may look like minimizing slang or jargon and keeping language very straightforward. And it may also be necessary to provide ample processing time. Trained American Sign Language staff can also assist, as there may be individuals who struggle with verbal communication but can quickly pick up ASL sign language. Picture cues, picture symbols, and visual schedules can help. Visual schedules can help with that planning piece and support that deficit. Picture cues might help if there is any sort of difficulty with linguistic acquisition. There are adaptive communication systems that may be used, such as the Picture Exchange Communication System, commonly known as PECS. It's a low-tech system which supports spontaneous, self-initiated communication. So that helps fade prompt dependency and it encourages individuals to seek out their communication partner. There are many other mechanical aids in communication systems. These include low-tech ones such as Big Macs, which is a sort of large button, mechanical button, which can be pressed, and there may be a pre-recorded message from a clinician or a teacher saying, requesting a break or saying that they need the bathroom or would like a snack. There are Dynavoxes and augmentative and alternative communication, AAC devices, or eye gaze electronic devices for speech. So this may include different sight words or commonly used commands or preferred staff or family members. Here we have a eye gaze system, a PECS book, and also the visual word overlay for AACs and Dynavoxes. There are many strategies to support instruction. As we discussed earlier, those clear and consistent expectations. Relationship building and trust is very important, to have those consistent expectations so that the individuals have an understanding of what is actually going to happen, and they can trust that their staff is going to follow through on those expectations. Well-defined and accessible schedules and routines with those visual supports included as needed. Also the use of positive behavioral interventions and supports, PBIS, so that students aren't being punished. Instead, they're being supported through interventions, which help them to develop coping mechanisms and work through their challenges. Reinforcement systems, so that individuals know what they are so that they can gain motivation and what they're working for, as well as adequate staff training and professional development to encourage that trust, empathy, and relationship building.
Research has shown that individuals with an intellectual disability benefit from inclusive teaching because it removes barriers, encourages participation, considers a variety of learning needs and preferences. A couple of teaching strategies of inclusive teaching include providing outlines of what will be taught, assistive technology, like those in the previous slides, reinforce learning by using real life examples, making it so that they can relate to what they're learning, using a range of formats that might include handouts, worksheets, videos, concept maps, flowcharts, using color, highlighting to distinguish key facts and information, oral feedback rather than written feedback. Assessment strategies are also a major component in inclusive teaching for those with intellectual disabilities, allowing extensions, encouraging student to turn in a rough draft for feedback, formative assessment, giving them a benchmark to see how they're doing and then elaborating based on that, allowing extra time if needed. Short answer questions over multiple choice questions are usually beneficial because multiple choice questions give them more options, whereas short answer questions, they can write down all their thoughts and how they're thinking. Exam timetables, letting them know how many days until their next exam, how long they'll have on the exam, what's to be expected of the exam, what's going to be on the exam, and then keeping written examinations directions short, avoiding bullet points to be less confusing to the individuals.
Some discussion questions. What is the difference between the DSM diagnosis of intellectual disability and that of the American Association on Intellectual and Developmental Disabilities? How might residential living look different for one adult with mild intellectual disability and another with moderate intellectual disability?
Imagine you are working with a student with an intellectual disability and they are showing challenging behaviors such as yelling and hitting when prompted to do their work. How would you reduce this behavior and help them get back on task? What are some challenges individuals with intellectual disabilities may face in the classroom as well as in daily living? How might teachers and or staff build relationships with students who have an intellectual disability?